Hello, my name is Matthew Peterson. I am an internal medicine resident at the University of Florida. I will be presenting a case of Hodgkin lymphoma causing mass effect and tamponade-like physiology. We all know that different cancers can cause tamponade, but usually through a case of pericardial effusion. The pericardial effusion can occur via metastasis to the pericardium as well as lymphatic drainage blockage causing buildup of fluid. However, cases of actual mass effect causing this physiology is more rare. This case is a 25-year-old male with no past medical history presenting with 3 days of exertional dyspnea, orthopnea, and progressive fatigue. His associated symptoms are significant for a 60-pound weight loss, as well as night sweats, fevers, and chills. And overall, just not feeling very well. Upon further evaluation, a CT of the chest revealed this marked mediastinal lymphadenopathy and a large anterior chest mass. Echocardiogram showed mildly reduced EF. However, it was very concerning for dynamic changes of tamponade physiology. This included early diastolic RV collapse, late diastolic RA collapse, respiratory variation with mitral valve flow, as well as a decrease in um, left ventricular filling. Diagnosis was concerning for a type of lymphoma causing this tamponade-like physiology. There was an ongoing discussion with the medical team about how to best proceed with this case. Because of the tamponade-like physiology and the mild to moderate pericardial effusion, there was a concern that the fluid buildup was causing the tamponade. However, due to the obstruction of the mass, they did not have clear access. Upon repeat echocardiogram, it was determined that it was actually the mass effect that was most likely causing compression of the right side of the heart and not necessarily the pericardial effusion itself. Therefore, because of the difficulty of the procedure due to the mass, as well as suspicion that the patient's tamponade-like physiology was caused by the mass itself, a pericardial centesis was deferred at this time, and the patient was set up for serial echocardiography. A biopsy showed Reed-Sternberg cells, positive for CD30, negative for CD20, CD15, and CD45. This was all consistent with classic Hodgkin's lymphoma. The patient was started on a chemotherapy regimen and was improved symptomatically quite a bit. His orthopnea and dyspnea improved prior to leaving the hospital, and upon follow-up, he had recovered much of his functional status. Follow-up CT scan can be seen with reduction of the size of the mass, and follow-up echocardiogram showed resolution of the tamponade-like physiology seen with the echo. He had return of completely normal EF and no more RV or RA collapse. This is a relatively rare case, and as I alluded to before, the cause of tamponade is usually by a rapidly progressing pericardial effusion. This can be seen commonly with cancers. However, the actual mass effect causing this is more rare. Hodgkin lymphoma can present with pericardial effusion and has been associated with tamponade, but as far as our research goes, this was one of the first documented cases of mass effect causing this. Fortunately for the patient, the mass effect resolved with chemotherapy, as did his pericardial effusion and tamponade-like physiology, as well as his cardiac manifestations and symptoms.